Welcome back to Cureus Conversations. My name is Shreya, and today we have the eminent Dr. Salim Surani joining us today. Hi, Dr. Surani, how are you doing?
I'm doing good. Glad to be here.
Great, we're happy to have you. So, Dr. Surani, today we're going to discuss a new article that you've published in Cureus, utilizing artificial intelligence in critical care, adding a handy tool to our armamentarium. But before we get into your article, can we go ahead and discuss a little bit about your background and your pathway to your current position?
Glad to be here. I've been doing critical care for almost 27 years. So I graduated and then I did my master's in public health and health policy. I also have a master's in health administration, but I always have enjoyed patient care and teaching. So I have been instrumental in setting several intensivist model and ICU care and started several residency program. I started a pump grid fellowship program, pulmonary fellowship program. So I always enjoyed teaching residents and fellow, and the patient care is near and dear to my heart. So it's been very fruitful 25 plus years.
Wonderful. And it seems like a very noble profession as well. So thank you so much for everything you've done up till this point. So now turning into your research a little bit more, what initially drew you to the subject of artificial intelligence's applications to critical care? And what brought you to the point of writing this paper?
The key thing is that, getting into research is a very interesting area because I've been to Yale, Baylor, and University of Illinois. And then because of the family reason, I moved to a smaller community. So they had some residency program. And again, there was no research going on. So initially tried to encourage them was a challenging. And then as the time passed by, I realized that the hospitals concentrated more on the RUV. And even the major centers, the protected times were going away and the research was dwindling. So it started working in that direction. So hopefully try to mentor a lot of the residents and fellows and medical students, and even the young folks coming in the high school, try to mentor them as much as possible and try to create someone who can lead the baton forward. Also, I realized there was a lot of challenges in getting a mentorship in the developing countries. So I started working with folks from Pakistan, Afghanistan, Syria, India, Kenya, Tanzania, and Uganda. And that has been a very enriching but very challenging experience because sometimes you feel like you can do something in 4 hours yourself, and you end up in spending 30 or 40 hours in mentoring. But one of the best thing what I learned out of that is that a lot of the folks which we mentored, some of them even in high school, now they are chief of neurosurgery at university. They have several NIH grants. They have published more than 200 manuscripts. And some of them are the cardiologist program directors. Some of them are faculties in several universities. So in other words, trying to get folks from the developing country and even in the smaller community and try to get into research. Always, you try to work on 10, 15 people, and if you even get successful by 10% and that turn out to be a good researcher, I think that is the best reward you can get out of your profession and mentoring. It does come with its challenges, no doubt about that, but I think it's still, when you see the success of your mentee, I think nothing is more powerful than that.
Wow, very well said. And so, where does AI fit into this pathway to becoming a researcher and your research?
So I think, we cannot ignore the technology. If I, go somewhat switch backward, I think the traditional practice of medicine has changed tremendously. I was at Yale, and a lot of the folks I worked with them, they were the one who actually designed the DRG, which came out from the Yale Harvard corridor, and it was designed as a research and quality assurance tool, and it then got and changed our medicine, and then we started getting compensation for that. Then the internet actually came in my time. We never had an internet before. We never had a cell phone before. And the Google came in, and that were a disruptor and a game changer. So when AI came in, obviously, you have a lot of fascination for AI because you always believe that the AI can analyze and change the things and diagnose the people disease even before the symptom happens. So I think that's one of the most powerful things. So if working in an ICU, if I know that which patient has a potential for going downhill, that can be observed closely, or if they don't have any potential for going downhill, we can just observe them in the telemetry or in the regular floor. That can be a very cost-effective medicine. And we know that, if you look into the AI and if you apply the sepsis alert or the ARDS alert, you can actually decrease the mortality by 60%. You can decrease the readmission by 50%, and you can actually save or decrease the length of stay by 10%. So it was not really something which was not driving towards. So I think some of the area of the research I did myself was AI in the sleep medicine, and we published several papers on that. And our goal was to try to come up with the diagnostic model without spending a penny, and we can predict the patient who can have the sleep apnea before even they have a symptoms. So we had published several landmarks paper in trying to come up with a screening of the sleep apnea. Before the stop bank, we had a Berlin question and names. Names were written by us. And then as the time goes by, what we did was we tried to see that if we can use some model like just the BMI, neck size, and airway, that is, everyone knows that, and we can utilize that mobile phone device. And can we predict this patient who are going to have a sleep apnea? That was something we did. The other study we tried to did was someone who has a COPD and or somebody we suspect having a COPD, and we did the spirometry or pulmonary function test. And we found that actually AI was performing much better in predicting the people who will have a COPD than a pulmonologist. So with all those years of training and some AI model, we feed in the data of about 1,500 patients spirometry and just use the demographic and symptoms, we are able to predict which patient can get the symptoms. So that was the interesting factor. And we started looking into the AI more. So that comes in since you're working in the ICU. So we felt that we need to try to pass the word around. And I think this paper was published a couple of years ago. And we did the same type of paper in using AI in cancer therapy. So if you take it just today in the World News, it is reported that they are using AI to discover the antibiotic to deal with the superbugs. And the AI was able to go through the molecular analysis in 2 hours. They went through the 6,000 samples, which can take months and months for any one of us to perform.
Wonderful. And it's so nice to hear about your background in research. So now pivoting a little bit towards the present, can you walk us through your paper that you've published recently?
So I think, what we are talking about, the critical care using the AI intelligence or artificial intelligence. What we did was try to do a very brief review. And what we discussed was what the artificial intelligence is. It's a computer system with human intelligence system. And machine learning is what we call is a branch of the AI. And we know that, the artificial intelligence or machine learning has been very good. The radiological imaging, now a lot of the imagings are being read by computer, and the computer is better than the radiologist. Look at the retinal scan. We go to the optometrist and the computer just scans, and their prediction and diagnosis is better than most of the optometrists. We look into the pathology, that symptom and pattern recognition capacity of the computer is far higher than that. So we laid the background, and then we try to address 3 or 4 things which we see in the ICU very commonly. One was sepsis, the other one was mechanical ventilation, third one was ARDS, and fourth one was again the mortality and the length of stay. And when we take into the role of the AI in sepsis, we found that the studies have clearly shown that if you are using artificial intelligence, they are able to predict the sepsis accurately, sometimes even as early as a couple of days before the septic shock really happens. So if somebody coming in with a simple infection, and we can treat on the floor, but if the AI model can use the algorithms, and the beauty with the AI compared to the computer algorithm is it keeps on learning from all the things and all the data which are being fed to. And if it can tell that few days before the patient is going to go into a shock, we can actually take a more better measure. We can do more appropriate intervention and prevent that. And that is how the later studies in my paper showed that it can cause decrease in the mortality by 60%. It can decrease the length of stay. It can decrease the readmission. Similarly, they created the septic alert system, and those alerts systems which were designed, they can actually tell us much before the sepsis is going to happen that this patient is going to go into a sepsis and septic shock, so we can do the intervention way earlier. Then later on, we look into the mechanical ventilation, and what we look into the studies and data, some of the key data, what we found is they look into a lot of parameters on admissions. And we used to have Apache scores and SOFI score, but this looks into a lot of the patterns and the parameters, and they can actually help us predict which patient is going to require the mechanical ventilation and which patient may require the tracheostomy. So we can actually do the intervention, try to prepare the family, try to prepare ourselves, modify our treatment, and hope that they never go into that area. So the beauty about the AI is it can predict the deterioration or requirement of mechanical ventilation much better than the clinicians. Then we look into the ARDS, and what we really found was that if we take a clinician for prediction of which patient is going to go into ARDS, were somewhere around 30%. And when we use the artificial intelligence, it turned out that almost 80–90% of the patient can be picked up. And a lot of the patient can be picked up before they even go into ARDS. So the protective measures can be implemented, and hopefully we can prevent several of those deteriorations.
Wow, that's amazing. And plenty of applications to the status quo as well. So congratulations on developing this wonderful tool. In terms of the work that you have planned for the future, is it related to AI? Is it going to be in the realm of critical care, which obviously you're very passionate about? Where do you foresee this work taking you?
So I think, one of the key factors, as I mentioned, that my role was to mentor a lot of folks in different part of the developing country. So anytime I mentor, I try to see what they're interested in, try to help them. So a lot of the work is different areas, but some of the areas in the artificial intelligence, we are actively working in the trying to work in the area of sleep medicine and COPD. And in the sleep medicine, what we have done and published several papers, we are just presenting another couple of papers in the artificial intelligence meeting by some of my artificial intelligence computer coworkers. And we are trying to come up with a application or a software design using your mobile devices and try to see if we can predict the sleep apnea before even patient have the symptoms. So if we can tell them that, based on this, you have a 95% or 85–90% probability of getting a sleep apnea, we know that we can do a lot of intervention, like losing weight, maybe get an early surgical correction if they have the anatomical issue. And similarly, if we can use the AI to predict who gets the COPD and who doesn't, we can save a lot of cost in the diagnostic modality. And obviously, using an application of the same tool can be widely used. And I think, there are a lot of the softwares which are going to come out. And one of the key thing is that you got to realize whenever you're using a computer, I still remember the old saying, GIGO, garbage in, garbage out. So you need to make sure that what data you're feeding and what you're expecting, that's what the expected outcome is. One of the biggest thing is, I think, we have seen the emerge of the ChatGPT and all the artificial intelligence bot. We just had another study done where we had the AI design, the research design, and the researcher designed the AI design, and we have just submitted that paper. And we send those to 80 of the top researcher all across the world, and we try to predict that. If they can predict which was written by the human and which was written by the AI, only 25% of them predicted correctly. And then we look into what they can say, who wrote the best research design and protocol. Guess what? AI with no medical background and urology background did better than a urological or nephrological researcher. So the AI was awarded. So I think, again, there is something that when you do use that, you're not going to learn. So you need to know what to do that. So biggest message is that the medical schools need to start thinking that we need to start incorporating some of the AI component in our armamentarium in the medical college. So they don't need to learn the computer basics and science, but they need to know that what you need to get out of it. Because in the past, we used to talk about time management. Now we need to talk about knowledge management because there's so much knowledge, how you can filter what is applicable knowledge and what is not. Otherwise, we are just going to go down in the pathway where we would be more confused than clarity.
Wonderful. And then I guess for our final question, what limitations and potentially dangers do you foresee, kind of related to what you were talking about when we were talking about knowledge management? Do you foresee, like, what dangers do you foresee with AI and its applications to medicine?
I think one of the thing is AI is not going to be an enemy. I think one thing we all realize, probably you may not, but in the past, we used to do the mathematical and calculus formula by our hand. Then all the sophisticated calculators came in. And guess what? We don't know how to apply the formula. We put the number and the answer comes out. The question is it relevant? Because it would take several weeks to do that. And that thing can be done within 20, 30 minutes. So obviously the AI is not an enemy. But at the same time, you need to understand that you need to have some basic fundamental knowledge. You need to know what you're getting out of it. Because if we're going to use the AI indiscriminately without thinking, then we are not learning anything. So you need to make sure that you can use the AI to help you, but at the same time, you need to use your own clinical judgment taken into the context of the AI and apply the technology to help you rather than totally lead the way for you. So I think it's a combination, mutual relation between the clinician and the artificial intelligence can be more successful rather than everything is just what AI says, you take it with the face value because they will have some limitation because if the data is not input right, your output is not going to be correct.
Wonderfully said. We can't use AI without the proper clinical judgment behind it. All right, well, that's all for today. Thank you so much for joining us.
Glad to be here. You have a wonderful day.
You as well.